It's just about noon, and it's time for us to begin our webinar for today. Thank you for joining us. I see we have many people who have been attending many of our webinars. I think this is the 12th in our series. I'm delighted today to have David Marlowe here with us. I hope you will not only learn a lot, but send in some questions as we go along so that we can engage you at the end as well. So let me tell you a little bit about our presenter and why we're doing this. It's truly an honor and a privilege to both know and have David join us today. He's a principal of Strategic Marketing Concepts, a healthcare marketing consulting firm down in Maryland. And he is directly involved in the development of strategic marketing plans, market research, marketing function assessments, medical staff marketing. And as we work with our clients, the work that he does is extremely valuable because all marketing isn't the same. Prior to forming Strategic Marketing Concepts, he was a vice president at a number of organizations, our strategic group, and marketing strategies. And he has over 35 years of healthcare marketing and planning experience. He's a frequent speaker at the major healthcare marketing and American Hospital Association conferences, and he's also co-author and editor of the book Building a Foundation for Effective Healthcare Market Research, and author of the books Healthcare Marketing Plans that Work and A Marketer's Guide to Measuring ROI. David, thank you so much for being with us today.
Thank you for having me here.
Let me tell you guys, it's really fun working with David, so it's lovely that we're together. But let me tell you why this webinar series emerged, so we put it into the context. Because what we see happening is that the speed of change is taking place so quickly that people aren't quite sure what to do, and in some cases have stopped doing things waiting to see what should be done. As an anthropologist, we work with clients in an anthropological way. We step back and we watch what's happening and we see it in the field and try to provide that kind of perspective. So all of our speakers share with us that in the field, close to see what's going on and how to get it done. So it's real important that we be able to share it and quickly and then make it available widely as a post-webinar video on YouTube. So all of this will be there for you and you can begin to look at it often. We have a physician who shows these to his residents, and we have nurses who attend and also watch them afterwards. They're looking to see what's coming and what's coming next. We have folks who have marketing companies, as well as those who are in the industry itself, and many from hospitals today with us. So these are some of the things that we're seeing and why David's talk was so timely. When things change, we need to know what it really means, what is the data, and what is really, really important from what we always thought was. Can we see the leading indicators? What's beginning to shift? And how do the trends from the past, the lacking ones, begin to show signs that they are subsiding in some way? That question about the return on the marketing investment is a classic one. Is marketing an expense or a revenue generator? Is what we're doing going to generate more interested and qualified patients, or is it just to build brand equity and brand awareness? Shall we trust what the data is telling us? Is there real life behavior in there? And we're working on one project with a client, and listening to the consumer talk about it puts feeling around the data in ways that's hard to imagine. Trust. Can we trust it to help us change our methods so that we do better and respond to the changes? So these are all the things that become really important here. A picture that I show here is typically what doctors saw in their offices. This is what they're seeing now. I can't tell you how many doctors are concerned about the traffic that is in decline, the lapsed patients. And one doctor said to us that with their deductibles, they're reluctant to spend money on things that are necessary, from the lab work that has to be done or the x-rays that have to be taken. We're also seeing that hospital advertising really needs a shot in the arm. I give the picture, but I thought it captured it so well. The traditional push advertising isn't working as it used to. And all too often, whether it's television or billboards, the consumer isn't coming to call or to the website the way they thought it might. With all transparency, we are fans of inbound marketing, and we really working well with clients to find out who's searching for them, how to convert them into patients, and then how to analyze the data to see how it's actually turning into a return on that investment. And the dashboards, which David will be talking about a lot today, are extremely timely and give you great resources to use to decide what to do more of, what to stop doing, and what to change. Remember, as we begin this process, that the old adage is true: you manage what you measure, and you move to those things that are important. Times are changing. What should you manage? What should you measure? How should I measure it? Who should I tell? What does it all mean for you and your organization? So now let me introduce David and turn this over to him. And we'll come back at the end, both for your questions and to sum it up in terms of the context and to set it in the stage of what's coming in the next webinars next month and in January. David, can I turn this over to you?
Absolutely. Thank you. All right. Well, good morning or good afternoon, depending on where you are, I guess, geographically. Let me start off with a slide that I actually don't have there, which is a definition of marketing. And I just want to put some context to this entire presentation. Philip Kotler from the Kellogg School at Northwestern 40 years ago defined marketing as the management of exchange, which I've always found to be a great definition because it doesn't use the word advertising or promotion or media or anything else. It just says we recognize that we want to have an exchange with somebody between two companies or a company and a person or two people. And how do we facilitate that exchange? That's marketing. And as a result, you take a very broad view of marketing. You can do a great job with an ad campaign, but if you can't get an appointment for 6 months, you've got a marketing problem. And if you can get that appointment, but you can't park in the same county where the building is, you've got a marketing problem. Or these days, as Andrew pointed out, high deductibles, if your price is wrong, you have a marketing problem. So it's a very broad context. I just want to say that because you'll see as I go along, I try to take a very broad view. Another great marketer, Albert Einstein, I don't know if he thought himself that way, but he said everything that can be counted does not necessarily count, and everything that counts cannot necessarily be counted, which I think is a great philosophy when it comes to marketing and just metrics in general. It's very, very true. We tend to count things that, frankly, nobody cares about, and the things we sometimes should be counting, which just it isn't easy to do. When I do this program live, I ask people, especially those who are from marketing, to write down 5 marketing metrics that they actually report on a daily basis and just kind of put it aside and compare it to some stuff we'll have later. So if you are indeed from the marketing arena, and I know we have nursing students on this and a variety of other people attending, go ahead and do that on the side as I go along. So just to show you that this is not a new issue, we've been at this for a while, and Andrea said I've been at this 35 years. This is actually a list of metrics from a report that was given to a board of a hospital, believe it or not, in 1982. I mean, if anybody on the call says I wasn't born in 1982, you feel free to leave now. No, I'm sorry, I'm just kidding. But you can see some of the items that are on there, we're still tracking today. Some of this stuff is not new by any stretch of the imagination. But it's still a key issue. And it was an informal survey done of healthcare marketing leaders in an organization that I belong to, and they said, tracking and doing metrics is a great challenge for them. Their challenge is specifically, what do I track? Having access to the information, which is, of course, if you can't get the information, how do you track something? And having the resources to do the actual tracking. It's not like it's done in a vacuum. You have to have manpower, you have to have systems. And there's an adage that I use with my clients that says, if you're spending more money and time tracking than you are doing, something's wrong. So that has to be taken into account. So what are some of the challenges to metrics in the healthcare marketing arena? And I'll say healthcare. It's usually hospitals and health systems, but it's any kind of healthcare organization that wants to do tracking. Well, first of all, unlike our colleagues in finance, those of you on here from clinical areas or operations, you all have external sources that to some degree dictate what you have to measure. So the finance people have the financial accounting standards boards and the bond rating firms, and the clinicians have CMS and JCO, and operations have JCO. We don't have any of that. Moody's, which is the bond rating house, doesn't sit there and go, oh, if you don't have so many visitors on your website per month, we won't rate you, AA. And JCO, frankly, could care less what our preference ratings are. So there is not a third party telling marketing people this is what you have to measure. It's also not at all unusual. I apologize, folks. I want to make sure I didn't skip a slide. It's not unusual also to find that even within organizations there isn't a consensus on what should be tracked. And this just came up recently at a client engagement, modest size hospital, where the CEO and CFO said, this is what I want to track. And the board said, no, this is what I want to track, or this is what we want to know. And marketing said, you know what? We're just going to focus on what we can actually control and touch. So there you are in one small organization, they didn't even agree on what should be tracked. So again, a challenge for those of us who do this. Another issue that comes up is what's marketing actually control? I told you in the beginning I have a very broad definition of marketing, but the reality is that most people in a healthcare marketing setting tend to pretty much control the communications related activities. They don't control the design of the product. They don't control the clinical outcomes. They don't control some of the things that impact patient satisfaction. So do we measure those things, or do we limit ourselves to only what we control? And that's kind of a cultural debate. I push my clients to take a very broad view and measure everything they can, but others say, no, I don't want to do that. For example, and these are actual quotes, I don't name names to protect the innocent, but one person said, we manage all digital activities, so web visitors and social media, that's fair. But we don't influence referrals made by primary care doctors to our specialists, so we don't track that. Yeah, well, okay, but that's certainly a marketing issue. Another one said, our focus is on brand image. I know the CFO wants to see hard returns, meaning money, but we don't control those. I have to convince them that image-related metrics are strategic. So there's a chief marketing officer saying, even though the CFO says they want to see a return, I have to convince them that actually what I think is important should be tracked. And not that image is not important, but you see the dichotomy here between what one party wants and what one party wants to report. There are a lot of, in our field, specifically in the marketing arena, we've got a real problem, a real challenge with the timeliness and availability of data. A lot of stuff is sometimes not done. It's not unusual to walk into a health system and discover they haven't done a consumer survey in a number of years. The call center may not report to the marketing department, so they can't get data from them. If we want to do ROI tracking, finance can't tell us what it costs to provide, what the cost of services sold is, so which you'll see a little later makes it impossible to do ROI tracking. The state database is 2 years old, and California OSHPD is the agency that tracks inpatient activity. When they had their financial crunch in California a year or so ago, all OSHPD tracking stopped. So there we were without any market share data in the state of California. Also, having the resources. Marketing metrics don't occur by some magic wand. You've got to have some people and some systems doing this. I've worked with some large systems that have big marketing departments, and they have a 5, 6, 8, 10-person team. But that's unusual. Not everybody has that. So what do you do when you've only got a 6-person marketing department and, frankly, nobody's dedicated to metrics? Well, one, you've got to limit the number of metrics to a reasonable number. Maybe you want to track 30 things, but you only may have the manpower to track 10. So what are those 10 going to be? And you also need to get yourself set up and do this on an ongoing basis so it doesn't become one of these all-hands-on-deck scrambles 2 days before the board meeting where they want to see the data. If you've got it going all year round, then you're not scrambling at the end. Some resources are a challenge for us. So having said that, what are the categories of metrics in marketing in healthcare? What are we actually dealing with? There are 3 categories, and they're not a perfectly absolute siloed categories. The lines may get a little blurry, but most of what we could or should measure falls into one of these 3 categories. And we're talking production activity metrics, what I'll call marketing operations metrics, and strategic results metrics. And other people might use other terminology for these, but this is the terminology that I've come to use over the years. So what are production activity metrics? This is really the quantification of the physical work that a marketing department does. And you can see a whole long list there. How many brochures do we produce? How many events did we sponsor? How many tours do we give? How many videos do we produce? And you see a lot of marketing departments track this, the physical labor of what they do. Then we go into what I'll call marketing operations. So it's the quantification of the results that came from what we physically did. So if a production metric was how many events did we hold, a marketing operations metric would be how many people attended those events, how many calls came into the call center. Web systems have all kinds of metrics. Those of you that work with web know that there's all kinds of landing page hits and there's a slew of things. How many people read the newsletters we send out? Social media, and I will be the first to admit that I am not a great social media user. I'm on Facebook, but as I tell people, I will tweet when I fly. So that I'm not the expert in that arena, but certainly there are metrics related to social media, inquiry and conversion rates. You send out a mailing, how many people respond. These are all marketing operations metrics. The last category is of the strategic results metrics, and these are the return from marketing that actually supports where the organization is trying to go strategically. Is it trying to establish a certain market image? Is it trying to drive market share? Is it trying to capture business or influence an audience or whatever it may be? So some of the things that fall into strategic metrics, certainly things like preference and image, volumes and market share, absolutely. Number of referrals, leakage, membership if that's appropriate. Certain things we do have membership, not only fitness center, which I put there, but if we're, you see further down, enrollment and re-enrollment if we get into insurance products. Certainly satisfaction is a strategic metric. If we're getting into population health, if your organization, then certain metrics in terms of people's health usage and health orientation would be a strategic metric. And probably the holy grail, if you will, is ROI, or as I put it there, ROMI, return on marketing investment, as opposed to ROI, which actually has a somewhat different financial definition. So, 3 categories, all are important, but at the end of the day, when I see a marketing plan or a marketing department with a dashboard that basically only has metrics in the first 2 categories, then that's a red flag. That's a warning sign. That department's got a problem, because at some point the organization's leadership is going to say, come on, it's nice that you're doing all those brochures, and it's nice that we had 6,000 phone calls, but did we capture any more volume? Did I get more referring doctors? Are people donating more money to us? You got to give me something strategic. So I advise my clients on this, and if your marketing plan and your metrics don't have I think a healthy mix of all 3 categories, but if you don't have any of the strategic metrics, you're really walking on a tightrope. Okay, so that's kind of the what gets in the way, what makes metrics challenging for us, and then gets into the arena of what kind of categories of metrics. And obviously there's a lot more to this. We have an hour webinar here, so we try to cover a number of things. But let's talk about reporting metrics. Let's assume that you have indeed come up with what you want to measure. How do you report them? And the terminology that we've come up with are dashboard. I have to tell you, I don't know that I'm a great fan of that term, because to me a dashboard is something that you just glance at occasionally. I mean, most of us don't drive down the highway staring at our dashboard. At least I hope you're not, and if you are, please tell me so I don't drive on the same road with you. But we glance at our dashboard, and really we should be looking at it and analyzing it. So that's just my quirk. But it's not a new concept. I remember 25 plus years ago there were presentations at our professional associations about preparing the marketing monitor. That was a term that was used probably close to 30 years ago. Now it's dashboards. That's okay. But even for the fact that it's been around for a long time, even as much as 10 years ago, it was pretty rare to see some kind of regular report coming out of marketing, going to the leadership, going to the board. It was an unusual thing to do. Now I'd have to say, based on some studies that have been done and the work I do, probably 3/4 of the marketing functions out there, certainly all the big ones, the bigger departments, have some form of regular metrics reporting, though there's a huge array of frequency and types, but the vast majority are at least putting out some kind of metric. Now, if that sounds like, oh, good, we've got a majority, it's still only, there's still some that are not. And for those of you on the call who come out of the clinical world, could you imagine a nursing department or a medical staff office or a clinical area that didn't report any metrics, any outcomes, any data at all? It'd be unheard of. Could you imagine a finance office that didn't do fiscal reports every month? It would be unheard of. So we're still not quite in the same level as some of those areas. So let me report a little bit of this. I wouldn't even call this a survey. When I wrote this up a little earlier in the year, I sort of did an informal review of some organizations that I knew, just to get a handle on what they were doing with dashboards. So take this as a convenient sample, not a purely scientific survey per se. But it was a mixture of standalone hospitals, regional systems, academic medical centers, just looking at, do they have a dashboard, what do they do with it? most of them, everybody had a dashboard, so it wasn't a matter of who didn't, but how often they did it, most of them did it monthly. Some did it quarterly, some did bi-monthly, but the mode, remember your stats, the mode was monthly. Now, I'd be the first to tell you, and they would be the first to tell you, that some of the things they measured didn't change every month. So it begged the question as to whether monthly was really the right thing to do, but we'll talk a little bit more about that. Okay, who got these dashboards? Everybody said, I send them to the C-suite. I send them to the CEO and the leadership. But about half, though, said that, you know what, the board. The board also gets it, though, interestingly enough, they didn't always get all of the information. It wasn't unusual, especially in some of the larger organizations, for the C-suite, the CEO, to get a dashboard, and for the board to get shall we say, an edited version of the dashboard. The report style, boy, if there were 25 reports, there were 25 styles. And some of them had one page, some of them with no graphics. It was just statistics. I have one organization, believe it or not, every quarter they do a 50-page, or maybe it was even bi-monthly, I apologize, a 50-page bound-up, ring-bound book with advertising samples. It was enormous. This was also, honestly, a department with 85 people in it, so clearly they had the manpower to do it. But it was so you have everything from one extreme to the other. Almost everybody, I think it's safe to say pretty much everybody, had some kind of production activity metrics, like we just went over. How many events were held, how many materials and videos, how many press releases. They pretty much all reported that pretty regularly. And they also all reported, in fact, they did more reporting on what I'll call the marketing operations. How many events, how many people attended, a lot of call center stats, a lot of web stats, because everybody now has pretty sophisticated digital capabilities. So inquiry conversions, if they have CRM systems, how many mailings did we send out, and how many people inquired back? How many, and then they're still tracking media coverage, how many column inches, how many stories were produced, and so on. So the biggest category on all those dashboards was definitely in that marketing operations category, because that's the area where people tended to have the most information available to them. Most of these people, but again, not all, not all by any means, had some degree of strategic metrics. But interestingly, there was no single group of metrics that was consistent. So in other words, of that whole long list of strategic metrics, I can't honestly tell you that of 25 dashboards, all 25 reported a certain metric or a certain small pool. So I think that's very telling. Again, back to that issue of we don't have this national norm that says, let me take it back a step. For those of you that have ever read a audited financial statement, and Andrew didn't mention, my undergraduate degree is actually in accounting, not marketing, so I come out of that world. But an audited financial statement has a very, very definitive format. You don't mess with it, you can't finagle it, it's got to be in that format. We have no such animal on the marketing side, certainly not in healthcare. But some of the most common things, at least out of the 25 I looked at, consumer image metrics, which hospital do people prefer to go to? Market share, usually from a public source like a state database. And of course, those are limited because most states only track inpatient activity. And as more and more things go outpatient, we're losing the ability to really track market share. How many referrals was a common thing to track? Key audience satisfaction, mostly patient satisfaction, but sometimes they would report on physician satisfaction or employee satisfaction. And a few, and it was probably less than 20%, even attempted to do return on investment. And interestingly, almost all of them had some kind of CRM system, which I think Andrew's got up speaker next in January talking in that arena, which is a system that allows you to do more with tracking, but a lot of them were not even attempting ROI. And the second half of this we will talk more about. So let me walk you through some examples of dashboards, and I'm not showing you the actual dashboard because people didn't want those put out there, but just to give you an idea. So one was a suburban hospital, modest size, 150 beds, small medical group that was employed, and a small marketing department, 3 people. Most of that, and I did a monthly report, and I put in parentheses most of the time because, as the director told me, on occasion there would be times when they couldn't get around to it. It was mostly a text summary of actions. It was, literally just a listing of what they did that month as opposed to any kind of stats or graphics. And you can see some of the statistics they reported: web activity, referrals that came into members of the staff through the physician referral service, how much money they spent, and pretty basic stuff, with the exception of referrals made to staff physicians. None of it was what I would call strategic metrics. Okay, another example is a big academic medical center, which I guess is a redundant term. I've never seen a small academic medical center, but 700 beds, big faculty group, and a pretty good-sized marketing department of almost 20 people. They do a monthly report, but interestingly, theirs was part of the advancement report. Advancement is fundraising in that organization. So the marketing was under advancement, and it would be reported there. Some elements were only updated annually or quarterly, even though they did a monthly report. So it wasn't unusual to get their monthly report and see that some things hadn't changed. And they used a kind of a green, yellow, red light system. So they established goals each year in their marketing plan, and they would show are we on target, are we behind, are we ahead, kind of thing. And you can see again on the right-hand side some of the statistics that were being measured. A good mix again. Better than the community hospital in terms of some of the strategic metrics. But again, some of them were also operational, some of them were also production. Third one is a good-sized system, a single metro area. So this was a healthcare system all around one metropolitan area, as opposed to a system that's across 6 states or something. So they're concentrated in one market, like in Atlanta or St. Louis or a big city. By the way, it was neither of those cities. And the 10 hospitals, I think they're actually now up to 12 hospitals, 300 plus employee physicians, big ambulatory care network. And this is the one I mentioned earlier, had a marketing staff of, I put 80, I think he's up to 85 now. They do 2 dashboard reports. They do one weekly for the marketing folks and one quarterly for the leadership. So that their department was so big and so spread out, they felt they had to do their own dashboard just for the department. And they print them and they bind it. It's an incredibly elaborate operation. The quarterly report that goes to the leadership, you can see some of the statistics. It's a mixture of strategic, a lot of operational. Interestingly, they report on their budget, they report on staff changes. It's a very elaborate process. I don't know that everything there was needing to be reported, but the point is it was very elaborately organized. So you've got everything from a smaller organization that did a pretty utilitarian monthly report, almost just more prose language and statistics, all the way up to what may be one of the more sophisticated dashboards in the healthcare provider field today. So are there some guidelines for doing a dashboard? And I get asked this stuff all the time. And part of the challenge is, you see if you go onto some of the listservs in the healthcare marketing arena, people saying, can somebody give me a template of a dashboard so I can work with it? And the problem is it's almost like marketing plans. Andrea mentioned I wrote a book on doing marketing plans years ago, and I've updated it a couple of times. And people ask, is there a matrix, a template, for a marketing plan? And the answer is, yeah, not really. I mean, yeah, there are certain things that you look at common structure, but everybody's plan is going to be a little bit different. The same thing for dashboards. You can look at somebody else's dashboard if you want to see how something's laid out, but I think I don't think there'll ever be a standard dashboard for marketing unless some third party mandates that it has to be done a certain way. But I somehow never see that happening. So what are some of the guidelines for if you're going to produce a dashboard for your organization, or you want to take a look at what you're doing with your dashboard? Well, first of all, you need to include metrics that matter to the audience who's getting the dashboard, not to you. Okay, you have your bias, but at the end of the day, remember, you're doing this dashboard not for you. You're doing it for an important audience, and so the metrics need to be important to them. So choose metrics that matter to the people reading the dashboard. Choose metrics that matter to the strategic direction of the organization. Back to the statement I made earlier that not everything can be production and marketing outcomes. Consider what I'll call the so what factor. So basically, if somebody reads the metric and goes, yes, so, what does that mean? Why should we care about that? What does that do for us? And frankly, I keep the production metrics pretty limited, or maybe like the third example I showed you earlier, limited to the department. Honestly, it's reaching a point where the board really probably doesn't care how many brochures you've produced in the course of the year. They are going to care a lot more about the fact that public image has improved, or market share has increased, or the physicians are happier, or whatever is important to them. Don't assume the reader understands the jargon. Again, some of you on here are clinicians. God knows every area of healthcare has its jargon. So if you're sending a marketing report to operations and financial and clinical people, just as you can struggle with their jargon, why in the world would you think they wouldn't understand? They wouldn't struggle with our jargon. I would assume that most of the people on this call understand the terminology SEO and SEM. But I can promise you that I can go into a room full of people who don't come from the digital arena or the marketing arena and say SEO, SEM, and they're going to look at me like I have two heads. So we got to, when in doubt, explain what it is. Visual, I mean, for heaven's sake, the marketing department, if the marketing department can't produce graphics, shame on you. So you want it to be visual if at all possible, at least to the degree that you can. Number 4, I think, is very important. Keep it current or don't bother. If everything you're reporting is months and months or a year behind, then what are you reporting? Now, I acknowledge some things don't change every month or every quarter or even every 6 months, and that's okay as long as you acknowledge it. But if basically you're just reporting the same data month after month after month with no change, what's the point? Make it simple to access, read, and use. So access, how are you getting it to people? Is it sent out under some secure email that half the people don't have a password for? Or are you making it easy for people? Are they reading it? You ought to check once in a while. I had a client not too long ago that has been doing a dashboard for 3 or 4 years, and they dutifully sent it out to the entire management team every couple of months, and they were producing away. And as part of the marketing plan process, I went and did interviews and took copies of the dashboard with me to 30, 40 managers that I met with, and showed it to them and said, hey, what do you think of some of the stats? And a significant chunk of them looked at it and went, I've never seen that before. So, marketing thought the dashboard was going all over the place, and clearly it was never getting there, or it was just being ignored. So you need to check, is anybody reading it? Is anybody using it? Be honest. The client that I had there that was doing the red light, green light, if the results are not up to where they should be, you need to acknowledge it, and you need to indicate what you're doing to try to correct it. Hiding the fact that something isn't working is not going to work. Sooner or later, the information is going to come out. Finance people really can't hide when the cash flow is no good, and the clinicians can't really hide when the outcomes aren't good clinically. You shouldn't try to hide if things aren't working. You need to decide how often to report. Is monthly really, if 3/4 of the data you're reporting is only changes on a quarterly basis or semi-annual basis, then maybe monthly doesn't make a lot of sense. Or maybe you have a short version monthly and a longer version quarterly. It also depends, frankly, on the resources available. I mean, if you've got a half-time person who you can dedicate to this, then monthly may be beyond what they can handle. And frankly, does the audience care? I've sat in on board meetings where the board has largely said, I don't need a monthly marketing report, or maybe just a couple of stats. Quarterly's enough. Things don't change that often for that area, so we're okay with quarterly. So you need to match the time frame with what people want. You definitely need to decide how many metrics to report. I was on a committee. SHMID is our National Professional Association, the Society for Healthcare Strategy and Market Development. Some of you probably belong. And we did a joint task force with HFMA to try to develop a set of marketing metrics that the finance people saw as valuable. And that's a whole other story for another time. But when we did our first cut of metrics, just for discussion purposes, we had a list of like 75 different metrics, maybe even more, probably close to 100, that got whittled down over time. Nobody in his right mind can report on 100 metrics. It's insane. So how many do you report? Well, that's a factor of how available is the data, how much staff support do you have, or do you even want to put into this? Honestly, I think a good model is that most finance departments typically on a monthly basis will report about 10, maybe 12 key ratios, key results. Days in accounts receivable, cash on hand ratio. Typical financial report, you'll see maybe 10 or 12. I think that's a good guideline. I think maybe 10, 12, 15 metrics. Much past that, I think, boy, you're going to start burning people out. You need to focus. There are some general industry metrics reporting software out there, by the way, and there's some names there: iDashboards, Visual Q, Tableau. These are software packages designed to support marketing, actually all kinds of metrics, but they're not healthcare specific. So if you really feel like you need some kind of template, there are some sources, and you're welcome to go check them out. I honestly think your best bet is to just probably, ask some colleagues from other organizations, get a few samples, see what you like, look at what, look what your audience is comfortable getting, and then design your own. There is no magic formula for the dashboard. What's important is what goes into it, not really the physical layout. My opinion. The creative folks here on the call might argue with me that how it looks is equally as important, and I'll bow to your judgment. Okay, a little bit more on this, and then I want to devote the last 15 minutes or so to ROI tracking. Comparing to norms, one of the challenges we have with dealing with marketing metrics, there's a lot of pressure in our field to compare to standards. So the clinical departments are asked to compare their clinical outcomes to national norms. Financially, we get dinged now by Medicare for not meeting certain clinical norms. So the clinicians are way ahead. Finance has certain norms. There are established norms or averages nationally for metrics like days in receivable, and if you're not achieving a certain, whatever, 60, 80 days, whatever the goal is, in receivables, that's considered not good, and it may hurt your bond ratings. Human resources have all kinds of studies they do looking at salary levels across the United States or a region for certain jobs, or benefits, or turnover rates, or how long a job stays open. So a lot of areas have these comparative norms. We don't have that. We really have not come up with what I'll call absolute comparative norms out there, and I'm not sure we ever will. First of all, they're very hard to come by. What's a good range of preference share for a hospital in its primary service area? And I've done a lot of survey work. I can give you an idea of what typically I see for preference, but there's so many factors that go into it. A hospital that's in a rural area where the nearest hospital is 50 miles away is going to have a very different preference metric in its primary area than an urban hospital where the nearest hospital is 2 blocks. What's a good ROI on a direct mail campaign for bariatric surgery? We haven't been doing it long enough to have any kind of national norm that says if you don't have at least a 200% ROI, it was a bad effort. Those kind of numbers just don't exist. There have been some attempts to have some kind of standards, but it's more operational than it is marketing outcomes. Shishmid, again, that national association, every couple of years does a study called Marketing by the Numbers. Some of you have probably seen it, and they look at more operational things like what's the average staff size given the hospital beds or something of that nature. But that's not really marketing metrics. It's more operations. That's the closest thing we have. So that is a challenge for us. There's also a question is how important, frankly, are comparisons to norms? I think it's critical for the clinicians to be able to compare themselves to, recovery rates from surgery or infection rates and all the rest. I don't know if it's critical for us to do that on the marketing side. If you're a hospital system in North Carolina, do you really need to compare yourself to a national average, or is it really more important that you compare yourself to 3 other systems in North Carolina that you compete with? The odds that somebody in North Carolina is going to go to Idaho to get their health care is probably pretty slim. So my lean is, at least on marketing metrics, is to compare yourself, first of all, to yourself. Are things changing? Was your preference score, overall preference rating, 40% 2 years ago, and now it's 45%, and so it's grown? I would definitely want to compare myself to my true competition. Who would a patient potentially go to? Who would a doctor refer to? Who would somebody enroll with in a plan if they don't choose me? I just came from a city down south last week where I'm doing some work. I won't mention names. There's 4 hospitals in the metropolitan area. really, I mean, they need to compare themselves down there to the other three hospitals and maybe the hospitals in the big city that's about 50 miles down the road. Otherwise, I'm not sure the rest matters. The other area you could do is comparison to what I would call true peers. So maybe everybody in a particular geographic area, maybe the other hospitals in your system, if you're a hospital in a 20 hospital system, maybe in the same category. If I'm an academic medical center, I probably want to compare myself to other academic medical centers, not 100-bed community hospitals. On the other hand, if I'm a large medical group, I probably want to compare myself to other large multi-specialty medical groups. So peers, I think, is an important comparison. A couple of examples of what I'll call cutting-edge metrics now in 2014, and then we're going to dive into a few slides on ROI. So I gave you a whole list of potential metrics in the three categories. There's plenty more than that, but these are ones I've run into in the last 6 months to a year that were a little different. So I just wanted to share them. Patients turned away. There's a system that I know that basically tracks the volume lost because the operating elements within the system couldn't schedule or take a referral in a timely manner. In other words, a patient tried to get in to a doctor in the system or a service, and because they couldn't get them in a timely manner, the patient went somewhere else. And it's tracked via a number of metrics that this AMC does, formal, informal, so it's not a perfect metric, but they're able to track that they're losing X hundred cases a month or every quarter because people were unhappy with their ability to get in. I think that's a terrific metric. It's a hard one. It's very strategic, but it's a great metric. This is one, the share of healthcare expenditures from a finite population. This is one we actually had in the late 1980s, and then when integrated delivery systems went away, we sort of lost it. But basically it says if you are a true integrated delivery system with everything from hospitals to doctors to nursing homes to ambulances to home health agencies, and you are taking risk, you are an insurance entity too, you should look, your share should be really the share of the dollars spent on healthcare that you're controlling as opposed to maybe inpatient admissions. So if 100,000 people generate, whatever they generate, $5 billion worth of healthcare expenditures in a year, what percentage of that is flowing through your system would be a very viable metric for you to consider. There's another one that I ran into not too long ago where they did a correlation analysis between the advertising dollars that were spent and donations that came into their foundation. Interestingly, the development arm created this metric, and they tracked it quite well. They found that over a 4 to 5 year period, that the amount of donations that came in, or what they call donation conversion, tracked downward when the advertising went down, and it tracked back up. I didn't say it here, but they tracked back up when the advertising improved. So when the organization was more visible in the marketplace, they were able to convert more people to donate, which I thought was a fascinating finding, and I'd love to duplicate that somewhere else. That's a great cutting-edge strategic metric. All three of those are just, again, unique to a particular market, may not fit your market, but boy, isn't that more powerful than how many brochures did we produce this past year. Okay, so let's talk about return on investment. And Andrea mentioned that I wrote a book on this a few years ago. It's published by Health Leaders. I think it's still out there. It's now probably 6-7 years old, and I've updated some of the components of it in presentations. But this is the short version, the very short version, and I'm happy to answer questions about it later if you choose. But this is kind of the holy grail of metrics in marketing in healthcare, probably in any field actually. And we're talking about the bottom, strategic effort. We're not talking, if you go to your accounting textbook, the Accounting 101, ROI is return on owner's investment. It's the net income divided by the owner's equity. It's really not what we're talking about here. We're basically talking about what kind of revenue, net of what it costs to provide the service, did we get as a result of putting money into marketing. So if we put out $1 in marketing, did we get at least $1 back? Did we get $2, $3? What did we get for the ROI? I have to really emphasize, this is my soapbox, that ROI or ROMI is a specific process that shows a return. If there isn't revenue involved, it isn't ROI. This term has been so misused in our field, but it's making us look foolish, because trust me, the financial people know what ROI means. They studied this stuff when they were doing their training in their world. So when we come back and say, oh, we did a press release and we got a whole press conference and we got the reporters there and had our doctors speak about this particular issue. And the ROI is that we were on the evening news on all 3 channels. Sorry, that's not ROI. There's a metric for that. It's called media coverage, and you might even be able to get some dollar out of that in terms of what's the equivalent if you bought ad time. But unless you can absolutely show that there was dollar-driven volume that came in as a result of that, it is not ROI. Unless you can show that somebody wrote a big check and made a donation, it's not ROI. There has to be money attached to it, revenue, in order to use the term ROI. Some of the, and we've kind of talked about, so I've already really covered this, but calling something ROI when it's not kind of makes us look foolish, and there are other metrics we should consider. If you're going to do ROI measurement, if it can even be done, it has to be planned before the marketing effort starts. So before you dive into that ad campaign or that direct mail effort or whatever you're going to do, you need to plan out the ROI before you get started, because after the fact it's going to be almost impossible to do. There are, just like anything else, I remember I said there are no national standards for metrics. There are very few absolute rights or wrongs. It's kind of whatever the organization decides in the way of upfront assumptions and parameters is correct. Now some things make more common sense than others, and you'll see in a minute. But so if hospital A says that we will count this particular return as coming from the ad campaign, and hospital B says no, we'll only count this kind of return, they're both right. There's no absolute norm for that. There are no established norms for good or bad ROI yet. I think there's just too few places doing it. I think in another few years you'll see that change as the pace picks up. So if you come back and say, hey, we did this direct mail effort and we had 180% ROI. I mean, it's positive, but I can't tell you that that's better than a national norm. The only thing you can really do is compare it to other things you're doing and say, well, when we did a direct mail campaign for bariatrics, we had a 300% ROI. When we did it for some other program, we only had 120% ROI. So, maybe the bariatrics is a better return on what we're doing. That you can do. Not everything we do is aimed at trying to drive revenue. And if you're not trying to drive revenue, then ROI is not the right metric. So if your town has a 4th of July parade and they talk you into putting up a float at the parade, okay, the return is public goodwill. There may be a number of types of return, but ROI is definitely not it. There's a time delay in terms of doing ROI. Very few things we do in healthcare are going to get somebody to use a service the next day. Now there are some, but the reality is that most things. I mean, you can promote the fact that you've got wonderful heart care, but my heart's good, thank goodness. So I may not be there for a long time. So you're not going to see me. And the line I use when I do this program fairly regularly is, for example, if we're marketing obstetrics, I don't care how good you are, folks. You're waiting 9 months. Okay, so there is, or maybe a little less amusing, oncology. The course of treating oncology can be a couple of years. The ROI can take a while. You also have to take into account to what degree is the service influenced by a marketing-related activity. So is it an emergency service? Is it an urgent service? Is it an elective service? Not surprisingly, more elective services where people have time to plan and think it out and look at it, a lot more marketing communications impacted. All the advertising in the world is probably not going to have a lot of impact on where somebody goes for trauma neurosurgery after they wrap their car around a tree. But it certainly can have a lot of influence on where somebody goes to have bariatric surgery or a colonoscopy or a diagnostic imaging procedure or any of a number of other things where there's some time to think about it. So that's a factor that we have to take into account with ROI. Can the organization's financial system provide the information you need? I mentioned this earlier. If the finance people cannot tell you how much money came in from the people that you've been able to determine came as a result of the marketing effort, ROI stops dead in its path. And you have to factor in the cost of services sold. I'm skipping ahead here. I see a lot of ROI metrics coming out of companies that, especially the companies that do CRM systems, and they will measure that a certain amount of revenue came in, and they're smart enough to say it's net revenue, not gross, but they don't factor in the fact that for every dollar you bring in, it probably costs the organization 40, 50, 60 cents in direct costs to provide the care. So I think that has to be factored in. We'll talk more about that in a slide. Can the organization's marketing function effectively track the marketing effort to result B? What kind of tracking are you going to do? And the truth be told, that there's really a couple of different types of tracking. We'll come back to that again in a slide. But you need to be able to do. You have to have some mechanism. If you can't actually say, because we did this marketing effort, we got this return, you can't do ROI. Okay? Can ROI be done for the specific elements in a marketing campaign, or is it enough to track the entire effort? By that I mean, for example, typically when we do an advertising campaign, it's not at all unusual to use print and radio and direct mail and billboard. I mean, deliberately to use, and it's done for very deliberate purposes. It may be it may be lucky if you can measure the ROI on the entire campaign. It may be next to impossible to measure whether the return was higher for the radio versus the web banners, and that may be just more than you can bite off. Does the leadership have the patience to wait? It's not unusual. I hear we'll do a campaign, and 3 months or 4 months later at a meeting, the CEO goes, "So what do we get for that campaign?" Well, come on, you got to give it some time. Frankly, I think you've got to measure for at least 6 months, and probably considerably longer. But that's a problem we have, a challenge, and people want to get the information back faster. Are there other factors that create skepticism? And I'll give you an example. I worked with a system that showed they actually have a very sophisticated ROI process, and they showed positive ROI in a whole bunch of direct mail campaigns they did. But the market share has stayed absolutely within a tenth of a point unmoved in that market for the last 4 years. So leadership says, how can you keep having positive returns on all these efforts and our market share stays absolutely the same? Well, there was a reason for it, because as much as they were gaining volume in certain services, they were losing it out the other end on other services. But again, it created that skepticism among the leadership. So what do you need to have to actually measure ROI? Let's go through that list. We'll walk through an example, and we'll call it an afternoon here unless somebody has some questions. So what is it that you need to know? You need to define the specific service that's being marketed and what you're actually doing. So we're marketing bariatric surgery, and we're going to be doing direct mail, radio, and web banners. So we know what it is we're actually doing. You need to define the parameters of what you will or will not count. This is what I mean by planning the assumptions up front. I want these things agreed to with finance, with my leadership, before I start the marketing effort, not afterwards. So what will we count? So if Mrs. Smith gets targeted through different promotional activities for OB related, it's campaign related to having a baby, but she comes in 6 months and has orthopedic surgery, should she count? And I've had people argue, yes, we influenced her. I frankly think that's a stretch, but I want that agreed to up front. Now, what if Mrs. Smith is targeted, or Ms. Smith, is targeted for an OB promotion, but comes in and has GYN surgery in a short period of time? All right, maybe that's certainly in the same bailiwick. Maybe that counts. Do you see where you want to have this decided as to what you will or will not count in terms of coming from the marketing effort? What does it cost to do the marketing effort? Okay, and there are some direct costs and indirect. For certainly, if we did an advertising campaign, there's a cost to designing the ads, to placement, to buying those web banners, to any events. That's very obvious costs. But there's also what I call allocated support costs. If you're paying a third-party company to be your call center, and they're charging you $8 or $9 or $10 a call that comes in, and you're successful and you generate 5,000 phone calls, well, that's $50,000 you just spent. That's got to be counted. And there's staff time. If you put out 200 hours of staff time, you need to count that cost in the cost of marketing, because that's staff time that could have been used for something else. So how do you track the returns? There really are two ways. The optimal way is to have some kind of direct connection. I put coupons there because, in the consumer product world, if you get a coupon, whether it's electronic or paper, they can track how many people use the coupons. We don't use coupons in healthcare, but we do things like having a dedicated phone line, 1-800 lose weight. And if you call that number, we know that you were touched by the marketing effort. A unique website is another unique thing. Some kind of unique identifier number, especially with a direct mail campaign that encourages you to go to a website and take a screening test. You put in your number, we know you got the direct mail piece. And in the CRM world, with direct contact, whether it's email contact or mail contact, we can use control groups. We can have 1,000 people that we know didn't get the mailing, and then 10,000 people we know did, and compare the returns from the two groups. You can't do that with radio or television or print or outdoor, because there's no way to block 1,000 people from seeing it or hearing it. That's the optimal, but the reality is frequently we can't do that. So a viable measurement is to look at the change in volume over a finite period of time with some safety valve factor. So if we had 1,000 units of service for the last 3 years, we'll say, okay, after the campaign, for a year after the campaign, anything over 1,100 units, we will count as coming from the marketing effort. We're going to have a 10% safety valve that we're going to assume is just noise in the marketplace. Or maybe it's a 5% safety valve. That's, again, one of those assumptions you want to have up front. How long do we track? I think you have to track for at least 6 months. And if it's a more complicated service with a longer decision time, probably a year. I've done some in oncology where it's 2 years. There's no rule that says you can't do interim ROI metrics every 6 months. But if something like oncology, if you don't go out at least 2 years, you're shortchanging yourself in terms of the financial return, because the treatment modalities can take that long. Some other services can be shorter. If I'm marketing bariatric surgery, I probably will cut it off after 6 months, because if somebody hasn't come in and had the surgery within 6 months of the marketing effort, they're probably not coming. Okay, you need to account for two things: business we would have gotten anyway, and what's a new patient. So business we would have gotten anyway, unless the service is absolutely new, has never been done in our market before, there's a history. So if we're marketing bariatric surgery, I keep picking on bariatric surgery, but a lot of people do it, and we've had the program for 5 years, well, there's an existing stream of business, and marketing can't claim that 100% of the business that came in after the marketing effort came as a result of the marketing effort. There's got to be some accounting for the fact that if marketing had done nothing, there still would have been a stream of business. What's fair, probably the simplest way, is to look at your current market share. So if we have a 20% market share of bariatric surgery in the marketplace, and we do a campaign and 100 people come in as a result of the campaign, I would say, frankly, we'd only count 80. 20 of them will be assumed would have come if we had done nothing. Then there's also the factor of what's a new patient. Optimally, we should have, we should count really for recent patients, but how do you do that? So I mean, if somebody's been in our hospital for orthopedic surgery 3 months ago, and then they come in to have another orthopedic surgery, is that really a new patient? But there has to be some, you can take it to the other extreme and say, we're only going to count people that have never ever been in our hospital or our organization or our system ever in their entire lives. Well, the problem with that is twofold. One, that assumes you have medical records that go back to like 1910, which nobody has. But secondly, it also, if you're in a smaller community, for example, if you're in a town of 50 or 100,000 people, you're the only hospital, the odds are 90% of the population has been in your hospital at some point in time. So that's, the safest thing for new patients is to say, okay, we will count somebody as being new to our organization if they haven't been in our organization in the last, say, 2 or 3 years, maybe 4 years, for the service being marketed. So if I'm marketing orthopedic surgery and Mr. Jones comes in and has orthopedic surgery, if he hasn't been here in the last 3 years for orthopedic surgery, he's a new patient, and I'm going to count him as coming from the marketing effort. Okay, a couple more logistics. What do we collect from the volumes deemed to have come from the marketing effort? So if we did a good job and we generated 100 surgeries, and that's after counting for new business and counting for business we would have gotten anyway and so forth, we got 100 of them. What was the revenue that was generated that we collected? Gross charges mean nothing, and if you didn't get paid, that doesn't count towards ROI. So if we generated $1 million in gross revenue but only collected 600,000, then it's the collected revenues that we count. And then we have to apply direct costs. And if you remember your accounting classes, there's direct costs and there's overhead costs. I don't generally include the overhead in an ROI model. I've had people argue that you should, but my argument is, frankly, unless our marketing effort was so good that we had to build another wing, that counting overhead is not fair. I mean, that overhead exists whether we do the work or not. But if a patient walks in the door and has orthopedic surgery because of a marketing effort that we did, there are some direct costs. There's nursing staff time, there's supplies, there's drugs, there's linens. You've got to account for that. The fact that you brought in a dollar in collected revenue doesn't mean a dollar went to the bottom line. 50 cents of that dollar, 60 cents of that dollar went back out the other way to buy the supplies and the labor and the drugs to provide the service. So that has to be taken into account. Almost done, folks. What is the ROI formula? Well, you see it there in front of you. The ROI percentage is the net revenue that was generated as a result of the marketing effort, and that's net of whatever we collected, and the direct cost is the absolute net minus the marketing expense together divided by the marketing expense times 100. So just round numbers there. You can see if we had $50,000 come in, we spent $20,000 in marketing, the ROI is 150%. There are other ways to report it. You see there on the bottom line, you're going to report it as a ratio, but frankly, most of the time it's reported as this percentage. I will point out to you that times 100 factor that's there. There are two schools of thought. Some of the books that do this show that times 100, some don't. The only thing is to be consistent. If you use the times 100 methodology, then break even is 100%. If you don't, then break even is 0%. It doesn't matter which one as long as you're consistent. You don't want to do one campaign and do times 100 and the other campaign you don't, because you're going to have some very strange comparative numbers. So let me walk you through a quick example. We're actually down to the last half dozen slides, so we're almost there. Anybody has to bail, I understand, but if you'll give me 5 more minutes, we'll be through this. So the activity is a CRM-driven direct mail campaign aimed at knee replacement surgery. And the idea is to drive people into an educational class that they can meet the orthopedic surgeon. You know the model. You've been there. The ROI tracking will only count people getting knee replacement surgery. So if somebody comes to the class and has, surgery on their hands, it doesn't count. Okay? We're going to spend $32,000 on the marketing cost. Doesn't matter what the methodology is. The tracking is done directly. We know who got the mailing. We can tell who signs up for the class. We can tell who then gets surgery because we have the ability to track names and identifying information. Time frame, we said 6 months. If they haven't come in and had surgery within 6 months, they're not coming. Business we would have gotten anyway, we're going to use as a proxy the market share for orthopedic surgery, which is 20%. New patient definition, they have not been in our hospital in 3 years for any service. Now, I said earlier, normally we would do it for orthopedics. This client said, nope, as far as we're concerned, it's going to be they haven't been to us in 3 years for anything. If they were here 5 years ago, it's a new patient. If they were here 1 year ago, they're not a new patient. So there are the results. 18,000 people got the mailing, 112 attended the class, which, by the way, gives you a 0.6% response rate, which falls into that marketing operations metric category, by the way. 15 have knee surgery, and after you take out the business we would have gotten anyway and people who are new, it came to 11 that came as a result of the marketing effort from the way our model works. Net revenue that we collected was $159,000. Direct cost, well, you can see the numbers. So the net contribution was about $87,000. The ROI analysis in this one is 174%. Okay? Now, question comes up, is that good? Is that bad? It's positive. It's a positive ROI. If I was making 300% on my bariatric surgery and money was the only thing that was our primary goal, revenue, then I might put more marketing effort into the bariatrics and the knee surgery, but it is a positive ROI. But like I said earlier, I can't give you a national norm for ROIs on knee surgeries. Some of the ROI implications, if you say, oh, hey, we had a great effort, we had a 300% positive ROI, shouldn't we get a bigger marketing budget? Well, if you want to argue for it, I'll back you up. But, in theory, yes, but in reality, maybe not. Okay, the first $100,000 we put out might generate $500,000 return, but that doesn't mean the next $100,000 is going to have the same result. There's only so many knee surgeries to be done. There's only so many babies to be born. There's only so many heart tests to be done. There's a finite potential in any market. Rule of thumb from other fields is you keep doing the marketing until the ROI finally drops off to 0, and then you stop doing it until the market refreshes itself. So no, just because you had a successful return doesn't mean that if I spent $100,000 and got a $500,000 return, fine, give me $200,000, I'll get $1 million. It doesn't really quite work that way. I wish it did. So if you're thinking about getting started on ROI, where would you start? How do I get my feet wet? Well, some of the parameters I'd say for ROI to start with: good targets, services that are elective, have high degree of consumer participation. In other words, the consumer is very much involved in that process. A single finite modality marketing effort, direct mail through a CRM system, is a good one. It's harder when you're doing radio, print, banners, the whole 9 yards. Not impossible, just harder. There's a strong tracking methodology in place. The financial people say, yep, we can tell you what revenue came in from those patients, we can identify them, and what the cost of services sold were. So good. If you're going to get your feet wet, good areas to start. If you own employed, or if you have employed primary care doctors and you're marketing them, that's a good one. Bariatric surgery, joint replacement surgery, occupational health, screening events, fitness center membership. These are all good get your feet wet areas before you start trying to do ROI on cardiology campaigns or oncology efforts or so forth. What's next for ROI? I think as long as we have volume-driven parts of our system, as long as we are trying to drive volume, and it's not going to be all value forever, trust me, there's always going to be some degree of volume. We're going to be doing the ROI that I described above. If we do shift to a population health management risk model, ROI may change. The marketing efforts may be aimed more at enrollment and re-enrollment than they are driving surgeries, but that's still an ROI driven. And you may see a reverse ROI. If I've gotten a capitation or a risk payment of $50 million for a pool of people, I may now be using marketing to direct them to less expensive modalities and saving money as opposed to generating revenue. It kind of turns ROI on its head, but it's still viable to do. I have not done one yet, but I figure within a couple of years we probably will see that. With that, I believe I have hit the end of my slides.
And now it's my turn to wrap us up. David, some of the comments coming through is you're terrific. This couldn't be more timely, and knowing some of the folks who have been listening in, and virtually everybody stayed on board, so thank you so much. From a perspective of the field, what's going on in there, you couldn't have been more timely and relevant, and the changes that are coming, and I don't know how to measure population health, but it's coming. And all of the things that our clients are struggling with, how to do a better job of attracting and retaining the right patients for the right purposes and the right time, are all part of this marvelous conversation that you've had. It was terrific. Thank you all for staying. Let me wrap and give a little pitch for, I'm going to go out to January and then back up to December. Our featured speaker follows on to the conversation today in a very timely way. Corey Smith is a senior director at Health Grades. And what's happening in the buyer's journey to find a physician is that they're shifting from referrals or word of mouth to going online and searching. And so he's going to cover how hospitals have to adapt to the way today's consumers are making decisions. And I'll do another one on this in May, because I do think that the consumer, for any number of reasons, is changing, and changing both how they seek care, where they seek care, why they seek care. So there's a whole lot of in-the-field work that's happening, and that David took heart of today and set us a good stage. What will we do and how will we influence that? In December, on the 12th, I hope you will join me. I'm going to focus on building a culture of innovation in healthcare. I can't tell you the challenges as the times are changing. People have to adapt and adapt their culture. And as an anthropologist, we have both a methodology and an approach that's well validated in many industries. But in healthcare, I've done several hospitals to assess and diagnose their culture today and move them in new directions. Where do they want to go? Become more innovative, more enabled, more empowered, more able to make quicker decisions and the right ones. Look at those numbers that David looked at and tell you what they should do next. So that's what I'll be doing in December, and I do hope you can join us then. And what I'm going to do for the questions that came through is I'm going to put it together as a blog. I usually like to follow up this with a blog and a link to the slide share and YouTube videos. We take the audio, attach it to the slides, and put it into a document that we send to you so you can share it and watch it. But I'll also put together the questions that came through. David and I will put together some answers, We'll put it
Yep.
into a blog and send it out to you. I hope that's good. I don't think we have enough time today. We've already been past our stop time, but it's been absolutely wonderful. So, David, I thank you so very much, and I'm going to sign off and wish you